Okay, welcome everyone. We're here today reviewing what we call PED 4, which is the class where we're going to talk about designing and implementing cranial molding treatment protocols. And as I've said before, a lot of the times osteopathic practitioners in Canada learn how to implement certain techniques, the theory behind them, refining their palpation skills. But what we are not required to do, because we're not regulated here, is to know how to do case management, how to take on a patient from inception, from the initial assessment, all the way to discharge. And as I mentioned previously, in countries where osteopathy is regulated, you have to be able to prove before the regulating board, in order to be licensed, that you know how to do this. Also, since you're taking this course, you're looking towards being certified by the Center for Continuing Education in pediatric osteopathy. And that means not just learning techniques or not just learning protocols, but once again, learning how to be able to set up and manage your practice so that you are a recognized expert within the field of pediatric osteopathy. So cranial molding protocols is a classic example of that, because we're going to look at important things like the context in which cranial molding takes place, the medical understanding about plagiocephalies, their orthopedic approach, how osteopathic philosophy and osteopathic cranial treatments fit in, either complement or as an alternative to the classic medical model in treating plagiocephaly and cranial molding, how you would go about designing a treatment protocol, and how you can go about explaining all of this in a confident way to the birth mother who comes to you with a child where there are signs of plagiocephaly, where multiple treatments are going to be required. So cranial molding means that we have multiple treatments, and you need to be able to set up a treatment protocol. You need to be able to justify it. You need to know how to go about planning it. And you need to also understand the context in which the mother is coming to you in your practice, asking you for help with her baby, maybe because her family physician has referred her to some type of orthopedic or medical institute where a cranial molding helmet has been suggested as a medical allopathic solution. Maybe the mother's coming to you never having had a consult with a medical doctor where that has been brought up. Nevertheless, you know by looking at the child that you're going to need a series of treatments in order to be able to be effective, because when we're talking about cranial molding, we're talking about much more serious conditions, where, as we saw in PED 3 and in our previous courses where we discuss what happens during the birthing process, the various forms of cranial abnormalities that can present to you in your clinic, you're going to see that when you need to present and propose a cranial molding protocol, we're dealing with conditions that are going to require more than one treatment, and therefore are more severe conditions. So cranial molding treatment protocols imply that you now have a very advanced experience in how to go about handling these kind of cases. One of our students asked, what if you don't feel confident yet? Would you insist on a cranial molding protocol, or would you concede to the mother making the choice about going with cranial helmets? I sometimes did not feel confident enough in how to go about suggesting a protocol, and so the mother brought the child in for a couple of treatments, but then in the end she ended up deciding to go with the cranial molding helmets as an alternative. And I feel like if I had known more, or if I had known how to present my argument, present what I would be able to bring to the table, maybe I would have been more confident in how I would have handled the patient, and I would have been given more of an opportunity to be able to address the plagiocephaly using a much more natural and safer and healthier approach with cranial osteopathy. So these are the types of questions that come up. It's all very normal and natural. If you're first starting out your career in pediatric osteopathy, if you haven't seen some of those more extreme cases that we discussed in our previous classes, that you might not know, well, how do I go about managing this? Where do I start? So this is what cranial molding protocols today is going to be all about. Okay, so we're going to talk about some of the important factors to look at during the birthing process, or a little bit of review, so that you know that indeed this is a case where the cranium of the newborn didn't have an opportunity at birth to be able to expand the way it should, for the bones to be able to position themselves properly, for the sutures to be able to disengage, and for then the baby's cranium to be able to grow in a healthy way. Something went wrong somewhere along the way. That's why you're looking at the possibility of as a series of treatments. We're going to look at how the medical field, how the allopathic medical field perceives plagiocephaly, what they propose as their alternative, what they perceive in terms of how intervention should take place, whether or not they feel that cranial molding helmets is sufficient. And we're going to look a little bit at why parents seek out you as an alternative, but also possibly as an adjunct. What is going on in the mother's mind, so that when she comes into you, you already understand the context. You're already well informed of the context of a mother who might possibly have been recommended a more serious orthopedic approach, and she's looking for something maybe a little bit more gentle and natural through you. We're going to look at how you go about designing a treatment plan, the factors that you need to take into consideration, what you should recommend for any case that is going to involve several treatments, how to deal with possible things that might go wrong in terms of attrition, parents not showing up, not being able to follow through, what are realistic expectations that you should place upon yourself in terms of the amount of results that you can offer, what kind of results you should expect with each treatment. Should it be incremental or can it vary? All so that you can be able to function in a way where you're confident and you can say to the mother, indeed, this is normal, this is what's going to happen, this is what we can expect, this is how I'm going to go about doing it, and this is the outcome that I hope. After this much time, we're going to sit down, we're going to reassess, we're going to go from here, right? So you're acting as a consultant in a case with cranial molding treatment protocols. You're not just doing treatments and the mother comes in when she feels like it. It's very much all about case management. We're going to look at some of the key things that you need to keep in mind when you're doing your treatments, and we're going to review very quickly some of the most important techniques that you want to keep in mind when you're going about administering your treatments throughout your protocol. Okay, so I've reviewed some of the questions that you've sent me, and what I'm doing is I'm trying to incorporate all of them as I go along. And hopefully, if that's going to work for you, if you have any other questions that I didn't cover today, then by all means reach out to me. You know that our main email address at the Center for Continuing Education of Osteopathy is ceosteopathy@gmail.com. And if any of you are watching this video for the first time because you're not enrolled in our cranial and pediatric osteopathy certification program, my name is Maureen Maher. I'm the educator for the Pediatric Osteopathy series, as well as the Cranial Osteopathy series and the series in Women's Health. Okay, that being said, let's go back. If any of you have your handouts handy, let's take a look and let's turn to page 3. And the reason why I bring up the questions of crying and suckling is because, as I mentioned earlier, there are two factors that are very important other than what happens during the birthing process, which we've seen in previous classes. You can go back, request the link to be able to watch those if you want. I'm not going to cover what goes on in the birthing process because that's for other classes, but I'm going to talk to you a little bit about two important factors that take place after the baby has been born that you need to keep an eye out for when the mother comes in with the baby, so that you can understand, what is the etiology of this? Where did it start? The mother might say, like, why is my child in this state? What's going on? So in the same way as when you're assessing, an adult who comes in and you notice they walk with a limp, oh, okay, look, I noticed that person's crooked. Or they tell you something, you're like, oh, when did that car accident happen? Oh, it was very recent, okay? Context. Same thing with cranial molding protocols and the newborn baby. So specifically, crying and suckling. So remember that, crying, suckling. So why crying and why suckling? Remember we said that within osteopathic theory, when the baby comes through the birth canal, right? So we're talking about a natural vaginal birth. We're not talking about a cesarean section. We're talking about when the baby comes through the birth canal, when they emerge from the birth canal, that crying, that initial cry, right? The good thing about nowadays, the husbands being present during a birth of their child, along with the birth mother, is very often they can be a second expert witness to me when I ask. I say, okay, when the child was born, do you remember hearing the child cry? Very often when you're brought children that need a cranial molding protocol, we've got some pretty severe plagiocephaly and malformation of the cranium. So you want to get context, right? You're going to go through all of the questions that we talked about in previous courses about taking history with the mother, understanding what went on during the birthing process. If the mother tells you the baby sat in the birth canal for a long time, and then they decided to do an emergency quick C-section in order to prevent the baby being stuck for a long time, the cord was around their neck, any potential complications which might have led to, anything other than a natural and easy birth, might have caused some distress to the cranium. Meaning what? Meaning that the cranium might have sat in the birth canal with the bones overlapping, because remember, we did talk about how they do go through a phase where the frontal is actually going to overlap the parietals, and the blood and cerebrospinal fluid is transsudated out of the skull temporarily when the head comes through that hard bony pelvis, right? We've got the pubic bone in the front, we've got the sacrum in the back. The cranium at one point gets compressed. The bones overlap. We already know this. If you don't, then request the link to go back and listen to PED 1, which is the birthing process. And so as a result, when the baby comes back out of, at the end, when they're born, the bones need to be able to expand out and take their natural place so that then as the baby grows, the bones can come together, the fontanelles can close properly, and we can have a cranium that is going to grow in a healthy, functional way. If the baby doesn't cry when they come out of the birth canal, the skull doesn't get that opportunity to take that full expansion, so the bones can remain overlapping. And here's where you can have a child which is what we call failing to thrive. Failing to thrive is a condition that you'll see where the baby comes, they're under their normal birth weight, they haven't achieved their developmental milestones. And once again, developmental milestones, you have that in your download from previous classes. And the baby is not latching and feeding well, they're underfed, they're underweight, their crying is not a big, full, booming cry. When mothers complain to me that their child cries, I say, big, healthy, strong cry is good. When we hear a baby that's crying and it sounds like a bleeding lamb going like, right? This is not a big, healthy cry. This is a sign of a baby that's failing to thrive. This is a sign that the cranial mechanism has not expanded with that big, deep breath, and wham, when the baby cries. This allows not just for lung expansion, but it also allows for expansion of the cranial bones that were temporarily forced into an overlapping position as it was coming through the canal, now needs to expand, right? This also activates the cranial mechanism. So within cranial osteopathy, we understand that that pumping, that expansion, right, that flexion and extension, that contraction and release, that pumps the blood, that pumps the cerebral spinal fluid, is an integral part of human vitality. We understand from cranial osteopathy that it is just as important as a beating heart for a sign of life. And so if the cranial mechanism has been locked, if the baby has come through and they haven't had a chance to take that deep breath, they're not sucking, right, and feeding properly, there's a lot of things that are not taking place in terms of the expansion and contraction of the cranial bones. That means that the baby is functioning in an overall devitalized state. When a baby sucks and feeds, which we'll see in our course on latching and feeding, that kind of sucking effect actually pulls on the palate, pulls on the vomer, pulls on the ethmoid, encourages internal rotation or a contraction of the cranial bones, right? So this is also another way for them to be able to have their elasticity, their external rotation and their internal rotation. So if the amplitude of the cranial bones is not full, then it stands to reason that the bones might be stuck in a certain position. Maybe the occiput is not going fully into extension. Maybe we've got, a very high elevated vault because the baby might, they might have used, which even though they don't use it as much anymore, but they might have used some type of forceps or vacuum to pull the child out. It does still happen. It's actually the reason why they're doing a lot more and more, preventative C-sections nowadays to avoid cranial, injuries at birth. Nevertheless, they do occur, and that's the context in which children who need cranial molding come to see you. So crying helps the ballooning out of the skull. Suckling and feeding actually allows for the opposite, that contraction. So the crying at birth and the proper and healthy feeding later is all going to be a sign for us that the cranium is moving properly. If during the birthing process those things didn't happen as well as you'd like, or the baby is still not feeding so well, this often correlates with children with severe plagiocephalies that are going to require some type of cranial molding protocol. So just keep that in mind. And if the mother says to you, why did this happen to my child? Why is this perpetuating itself? Why are the bones not going back into place the way they should? Why is my doctor recommending, a helmet? You can say, well, you told me that during the birthing process, the baby didn't cry, they're having trouble feeding. These things actually help with the cranium. These things didn't happen. So your child's cranium is actually developmentally delayed. So you understanding what's going on and being able to repeat it and explain it to the mother so that she can understand that what happens, what should have happened to the cranium, and what you're going to make happen with your treatments. So this is how you're able to explain that you're an expert in the subject. Okay, so in our previous class in Ped 3, we looked at the different forms of plagiocephaly and torticollis in a lot of detail. I'll let you review that on your own on page 4. And as I said, if you need to go back and review the class, you've got them. You can do it over and over as often as you'd like. Different forms of plagiocephaly are going to inform, the types of treatments that you're going to do. We'll talk about the details of treatments themselves in the end, but let's talk a little bit now about the context, the medical context. So remember I said that the medical industry, right, the allopathic medical field has their own way of viewing plagiocephaly. Their approach very often is what we call cranial molding helmets. And if you take a look in your notes on page 5, you'll see I've included an example of a child, very young child, wearing a cranial molding helmet, and on the back it's written, "My own shell." So first you'll see that the medical industry has a way of trying to put a rather positive spin on cranial molding helmets because having them fitted and wearing them, is not a pleasant experience. It's not a pleasant experience vicariously for the parent, and it's not a pleasant experience for the newborn either. So they try to make it as positive as possible. Imagine if you had to wear a cast, for a long period of time on your head. It's never fun. So the medical community tends to believe when it comes to the actual molding of the skull, if they haven't gotten to the point where they've recommended cranial molding, very often you're going to hear the mother say, the doctor told me do nothing. He's going to outgrow it. Okay, we see that a lot with orthopedic conditions. You might see that with a child that's brought to you that's between 1 to 3 years old, where it's a lower limb walking gait development issue. And they say, I don't understand why the doctor said to me, that my child will outgrow it. Like his foot is crooked and he can't walk. And my neighbor's child's the same age and he can walk. Why is he telling me to wait that he'll outgrow it, right? So you need to know that this is something that doctors often say and how you would go about addressing it. So you have to know, first of all, that nature, Mother Nature, does have a certain amount of ability to have corrective forces on anywhere within the body of the newborn, whether it be the cranium or elsewhere. This means that, yes, to a certain extent, the child will grow into, a better developmental state and will often outgrow a lot of things. The human body was designed to be able to heal itself. It's only when it is so stuck that we, as manual therapists, need to come in and, give a little bit of a helping hand, right? We function based on that principle, that in osteopathic medicine, we believe that the body has an innate ability to heal, and it's only when it gets stuck that we need to come in and start exerting some external force to help the body then be able to go on with its own natural healing. This is the logic behind the interval that some schools teach with regards to when each treatment's going to take place, because Mother Nature is going to step in and is going to do a lot of the stuff themselves. So to a certain extent, yes, the skull will continue to grow, but now it's a question of finding that fine balance between working with a mother that might say, you know what, I don't want to wait on human nature. Isn't there anything you can do now? And you say, yes. In fact, what I can do is with my treatments, I can just give Mother Nature a helping hand. So that's the way that I present that answer to my clients. You should also know that we're living in a time where car seats have become very popular. Throughout history, mothers have taken care of their children and carried them and moved them from place to place with different devices. And in different places in the world, different devices are popular and used more or less than others. But in the last 20 years, I've seen an advent of car seats and an advent of children spending a lot more time lying inclined, leaning up against their occiput on their back. Not as much tummy time as they used to have before, because there's a big concern of infant death, sudden infant death syndrome. And so when a child spends a lot of time on their back, and as we know that a lot of the plagiocephalies involve either a compaction, a compression of the occiput, some type of shunting, or maybe even a hyperextension of the occiput and of the brainstem in that area, when a child spends a lot of time lying on their back as well, that doesn't help. That can slow down Mother Nature being able to come in and allow the bones to be able to expand, and can also delay the results that you're going to offer in your treatments. So the medical community's solution to that is cranial molding helmets, or orthotics, or baby helmets, whatever they're called in different places throughout the world. Now, in some countries, this is very popular. Depending on where you're located, maybe less so, but you should know, as I said, it's all about context with cranial molding. You need to understand what the medical community might be putting in the head of the mother in terms of suggested solutions. So she might come to you and say, my doctor recommended that I go for a consult to have a cranial helmet made. I haven't gone yet. What's that all about? Do you know anything about that? And do you recommend it? And is there something that you can do instead? So you need to be able to understand, okay, what are these cranial molding helmets? Why would the doctor recommend them? What are the advantages and disadvantages? And where can you, as a cranial osteopathic practitioner, fit in instead? So know that when a doctor is suggesting cranial molding, whether it be the family physician or some type of orthopedic specialist that the mother has consulted with, they are addressing the human body in a non-holistic approach, meaning that they're addressing the cranium, right? They're not addressing any potential torticollis. They're not addressing any potential deviation of the spine. And as we know, and as we've seen in previous classes, torticollis is often interrelated with cranial abnormalities, and it's often a whole body dysfunction. We can have a deviation of the spine that has also come into place. We can have torsion within the fascia of the newborn, and so you need to release some of the entire bodily myofascial chains in order to be able to address a torticollis once and for all, in order to be able to fix a cranial problem, because for us, it's all interrelated. So when doctors are recommending cranial helmets, they're addressing the cranial bones only. They're breaking up the body, a lot like the physiotherapy approach, which I often say, if you look at their service menu, it'll say, this is our fee schedule. If we're treating one body part, it's this much. If we're treating two body parts, in other words, if I'm treating just your shoulder, just your knee, just your ankle. But for osteopaths, we don't work that way, right? The whole body is as a unit. There might be a reason why I need to work on your pelvis and, the fascia that connect the iliac to the shoulder, to the temporal bone, in order to be able to have an effect, a lasting effect on my cranial molding, for example. So know that your approach is going to be more global and more holistic. So when the mother is going to ask you, what can a cranial molding helmet do? Is that enough of a solution? You'll be able to explain to the mother how It's going to work localized way on the cranial bones, but us as osteopaths, we understand that there are chains. There are muscle chains attached to the cranium. There's the cervical spine attached to the cranium. And so it's not addressing other abnormalities or dysfunctions in alignment or functioning. If you've done a full assessment on the child when they come in, which you should have, you might have noticed, let's say that, there's some lack of range of motion. So you can say, well, not just that these are the cranial problems that I found, but there's also these other areas within the body that are interrelated because everything's attached. And I would recommend that we address these things as well. So the medical community might address the cranial problem in terms of the positioning of the bones and the shape of the head, but they have not addressed all of the other muscle, myofascial, and spinal chain links that I would like to see the child addressed so that when they grow up, they're healthy, they've got full of range of motion everywhere in their body, and it's not just a cranial problem that we fixed, but we haven't fixed the rest. This means that when you work with a newborn and doing cranial molding, you might be an adjunct therapy, meaning you might be a therapy that the mother chooses to do along with having the child fitted for a cranial helmet. You might be an alternative, meaning that the mother might say, you know what, I'm going to hold off a little while and I want to maybe do a few sessions with you. I want to see what you've got to suggest, right? So it's not always an either or. Sometimes you're working in an adjunct condition, and that's not a bad thing. And we'll talk about that later. So know that that's the context in which cranial molding helmets are recommended by the medical community. Let's talk a little bit about the helmets themselves. I want you to take a look at the image that I've included on page 6 of your handouts, and you'll see how a newborn, when they're fitted for cranial molding helmets, it's not a pleasant experience, right? Remember that the frontal bone alone makes up half the orbit of the eye. So if I want to be able to take a mold of the shape of your frontal bone, I need that helmet as they're being fitted with the plaster to come all the way down to here. That's why in the image you see the cranial molding as they're putting the plaster on, coming all the way down over the child's eyes, all the way down onto their face, right? So there's like barely this much that's not being covered. And we're learning a lot about trauma nowadays, trauma at birth. A lot of psychotherapy is trauma informed now. So I, posit the question, how traumatic is it for a newborn child to have this cranial molding helmet fitted for them? And can we help the child avoid that if necessary, right? So these are ethical questions that you need to be able to bring up to the mother. We don't have a clear answer on that because we don't have any longitudinal studies. But this is an ethical decision that the mother has to make. Does she want to put her child through the discomfort of having a cranial molding helmet made for them and have to wear it? Or does the mother prefer to bring the child in for treatments with you and have the child be subject to the crying and fussing that they go through with 2 treatments a week for X number of weeks, right? So these are ethical decisions the mother has to make. It's your job to be able to propose what you've got to offer, how your solutions might fit in and help, and then allow the mother to make an educated decision. You're not to denigrate other approaches, but you want to educate the mother so that then she can make an informed decision of how she wants to go about things and how she would go about it with you. So know that cranial molding helmets are sold, really. They're presented with a lot of positivity by the medical community because they want, the child for it to be a happy experience, and they want the parents who are looking at their child every day wearing this helmet, to not feel like, oh, look at my poor child stuck in this thing, right? So they'll write fun things on it, I'm working my head and this is my, happy helmet and stuff like that. So know that this is the type of, psychological sell that the medical community is doing that you're going to be up against. Remember also that cranial helmets are designed to guide the bones into place, okay? A cranial molding helmet, even though the underside, the inside, is actually got, a softer layer of tissue, it is designed nevertheless to be restrictive, right? And so as a result, a lot of osteopathic practitioners will tell you that when they've worked on a child who has been wearing a cranial helmet, the cranium of that child is often, and what did one of our students say? Hard as a rock, okay? Remember that for us in cranial osteopathy, we want those sutures to be able to come apart and come back together, right? This is a sign of a healthy cranium, so that increased blood flow, that the pulsing of the cerebral spinal fluid be able to take place. There needs to be some natural gymnastic movement able within the bones of the skull for everything that's taking place on a fluidic and cellular level underneath to have room to be able to function. We need the cerebral spinal fluid to be able to drain and be produced, right? We don't want those layers in between the membranes to be compacted and compressed to the point where, those cells are not producing cerebral spinal fluid well. We want to be sure that the venous sinus channels, where the blood, needs to drain out and through and back down through the third and fourth ventricle, that there is space for that, right? So guiding the child, just like a cast, just like any type of orthotic, can have a guiding effect, but it can also have a restricting effect. And for us, cranial molding is all about guiding the bones so that they're able to function properly. So you'll need to explain to the mother that in our view of things, we want to be sure that the skull's bones are actually able to move a little bit. So having some cranial molding treatments in between while the child is wearing a helmet, if they already are, would be a good idea, would be indicated. If the mother says to you, I'm thinking of waiting, after the child has outgrown that period, they said he had to wear the helmet until such a time. After he stops wearing the helmet, then maybe I'll bring the child to you if there's anything. That's like a mother who says, after I give birth, if I've got any pain, I'll come to see you. And I always educate people preventatively, say, if you have treatments throughout your pregnancy, you can go into your delivery healthy and a lot less pain. Similarly, if the child needs some cranial molding treatments, whether it be to even just disengage sutures and ensure that the bones are moving properly in flexion and extension, while the child is going through those months where they're wearing a helmet, you're helping the brain and the cranium of that child to remain healthy. So being able to explain that to the mother and help her understand why your cranial treatments, might be a good adjunct therapy is going to be important for you. So the helmets, remember, are restrictive. They shouldn't be too restrictive to the point where the sutures are closed, where the sphenobasilary symphysis is not moving properly. So I would recommend, if at least, at the very least, have a child who's already wearing a helmet, remove it and assess for the sutures, whether they're beveled, whether there's space, whether every cranial bone is able to move fully in flexion and extension. And if you see that there is a lack of mobility, then you need to explain this to the mother and say, I really recommend that we need to do a few treatments because unfortunately, this is one of the unwanted side effects of the cranial helmet. And so you can actually do both together to ensure optimal health for the health of your baby. So some of the other reasons why the mother has come to you looking for help, as we mentioned earlier, cranial molding helmets, because they're meant to be so restrictive, there's often a very strong cosmetic aspect of it, right? They're looking at whether or not the cranium now has a nice, healthy, round shape, right? But they're not taking into consideration the things that we look at within osteopathy, like, the compressive forces, which I just talked about, but also, the rotational forces when the baby comes through the birth canal, if there's been any type of torsion, if there's been any type of shock, if the cranial mechanism, is stuck in some type of spastic state because of the birthing process. If there's any restricted patterns, whether it be within the fascia, whether it be within the muscles, the alignment of the neck, the clavicles, all of that, cranial molding helmets don't take that into consideration. That's our job. So know that when the mother comes to you, you might say, okay, yeah, but you haven't thought about this and that, so let me tell you what you also need to consider. Also know that since the molding of the cranium is designed to be fluid, right? If the child is also going to go through periods where the fontanelles are going to close, we want to be able to check and make sure that all of that is going properly. So the orthopedic community has their own agenda about what they're going to check on the child as they go through regular appointments. The mother says to you, well, my child has already been scheduled for interval regular checkups. So that should be okay, that should be enough, right? And you say, well, what they're checking and what I'm checking is going to be two different things. This is what I check, right? And this is what's also important to me for the growth of your baby's brain and all of the factors that I just discussed. You need to be able to explain that to the mother. So she might say, oh, okay, so in that case, maybe I'll forego the helmet entirely. Maybe I'll go with just treatments with you, or maybe I'll do both. So educating the mother allows her to be able to make an educated decision. Now, I'm just going to take a little bit of a drink, because when I talk a lot, my mouth gets dry. Let's talk about designing a treatment plan. And this is very important because I want to come back to the subject that one of our students brought up in the previous class, which was, I had a child that was brought to me where there was some cranial molding needed. I know that there was a series of treatments required. Didn't have a lot of experience with having to deal with these types of cases before. The mother decided somewhere along the way to go ahead with the helmet. And I feel like I could have done more treatments, and I feel a little bit self-defeated in the whole situation because I feel like I wasn't really given a fighting chance to be able to address this with osteopathy. And also, if I had known more about, how to do that case management, like they call it in French, and prise en charge, taking in charge of the patient and what to recommend and what to advise, maybe I would have had more of a fighting chance to be able to help the child using a natural way. So what I felt the student said that I was lacking was how to go about everything we're talking about, including recommending a treatment protocol. This is what I recommend you do. This is what I want you to commit to. Then we're going to go ahead. Now, know that designing treatment protocols might not have been part of the mentality that you've been taught, depending on where in the world you're practicing. Know that sometimes you might have been taught how to administer treatments. And one of the things that I tend to reproach certain osteopathic schools in certain areas is that this is not taught. And so even myself, when I go to consult as a patient, I say, okay, when do I need to come back? How many treatments do I need? I want to just be able to be the patient and give the control to you. And the osteopath says to me, see how you feel and call me next week. Or even worse, see how you feel and send me an email. I'm like, what the hell is that? What kind of protocol, what kind of follow-up is that, right? It's not that the practitioner is lazy, it's just that nobody's ever taught them the importance that part of your responsibility is actually explaining to the patient what they need in terms of follow-up, making a recommendation so that they can make an informed and educated decision. Also, I don't know about you, but I don't like working on a patient where I feel like I'm always in reaction mode. Right? Where the patient says, okay, I'll call you when next time I'm going to come in. What? So like you decide, right? Every regulated health professional, whether it be the chiropractor who tells you these are how many sessions you need, this is the interval in which you need to come in, do it based on, absolute evidence. They're not just pulling this out of the top of their hat for sales purposes. They know that if they want to try to correct a deviated spine, you need 2 sessions a week for 3 months. I did it myself once as a patient when I developed a spinal deviation as a result of a prior profession and bad posture. This is what you need to break up scar tissue to get results. When you go to the dentist, they say, I want you to come back. You need a cleaning once a year, every 6 months, da-da-da. People take this as a given that their dentists even call them up and say, you're due for your next appointment, okay? So regulated healthcare professionals, part of their duty is not just to administer good treatments, but also to be able to advise you, be your go-to person in telling you what the interval that you need and what you should expect. If you cannot provide this when you're taking on cases of cranial osteopathy with newborns, then in my opinion, you shouldn't be practicing at all. You're dabbling in something that you don't know how to manage. And unfortunately, in countries where pediatric osteopathy or osteopathy in general is not regulated, there's a lot of people who can say, yeah, I do pediatrics, yeah, I do obstetrics. Okay, where's your formal training? What's your clinical approach? How do you go about doing it? And they never really had any formal training like you're doing with these classes. They're just winging it based on some techniques that they learned in school on how to do cranial techniques on a newborn, okay? So that's not being a healthcare professional, that's being a technician. We want to be healthcare professionals, and so we need to know how to be able to present a treatment plan. This must be part of your first appointment with the mother who comes in for a cranial problem. If you're working in a clinic where you're not accustomed to having enough time in your first session, if somebody is bringing in a newborn, the person who's making the appointments, whether it be the secretary or whether it be your online booking system, you need to have an online booking system or a secretary or yourself who's going to do a little bit of triage at the beginning and ask, what kind of case is this? Is this a pediatric case? Is it a pediatric cranial molding case? Or is it, some type of a cranial problem in a newborn? Yes. Okay. So now you need to be able to dedicate 1 hour for your intake. If you haven't done that in the past and you train with schools whereby your appointments are on the half hour, I'm very sorry. You cannot do a full assessment, explain to the mother what you found, explain to her the treatment protocol for cranial molding that you would recommend based on this patient. You're just winging it, okay? And in that case, you shouldn't be practicing in this field at all. And I'm sorry, but some people are not going to be happy to hear me say this, but I am trying to bring an international and higher standard, a medical standard and a professional standard to pediatric osteopathy in a country, Canada, where we're not regulated, where the College of Physicians and Surgeons are watching us very closely, waiting for us to slip up so that they can accuse us of practicing medicine illegally. And practicing medicine illegally can also sometimes mean being negligent, right? It doesn't always mean injuring a patient. It can mean being negligent in knowing when to refer back to a doctor, when to refer to emergency because it's a bad case, and knowing when to recommend a treatment protocol that makes sense and that also remains within your scope of practice as an osteopathic practitioner. Right? So here's where you have to understand where the medical community fits in, where you fit into all of that, and to be able to work safely, effectively, and within your scope of practice. So how does that all relate to designing a treatment plan? Well, you need, like I said at first, to be able to be sure that your first appointment, even with a newborn, is an hour. If you say, but my appointments are a half hour and that's the way our online scheduling system works, then you need to change it, point final, okay? Or don't try practice, plagiocephaly and cranial molding as an osteopathic practitioner. You need to be able to sit down with the mother and explain to them, okay, now that I've assessed the child, I've assessed the cranium, I've assessed the entire body, I've assessed for, all of the other things that we saw in the previous classes. These are my findings. This is what I recommend. And, if you're lucky that you have time to do a first treatment. Now, a treatment on a newborn will be maximum 20 minutes. So it easily takes me 50 minutes to an hour to go through all of that with a newborn and a mother. When I do, this is when the mother says, okay, this person knows what they're talking about. This is a real professional. I went to see somebody where he did one treatment and said, bring him back in 10 days. He's got a bit of gas. He's got this, like it just seemed very fly by night type of thing. When you sit down and you do a proper intake with the mother for a baby that needs cranial molding, you need to be able to go through an entire consultation with them. This is also what's going to cause the mother to develop a bond with you, to trust you, and to say, okay, so this person knows what they're talking about. Wow, they're recommending an investment of a series of treatments and time that I didn't know about, so I need to think about this. But this person knows what they're talking about. They've presented it in a very coherent and cohesive way, and so I'm inclined to trust them and follow their judgment. So designing a treatment plan is going to mean telling the mother, when we're doing cranial molding, we need to work, consecutively. So we need to do several short treatments. It's not a question of an hour-long session every 10 to 14 days. That's adults. Newborns that require cranial molding, and we know that within cranial osteopathy, we are most effective and we mitigate our side effects when we do shorter treatments with a more frequent interval. This goes back to cranial osteopathy and our findings with our forefathers over 100 years ago. One of the main reasons why people have one treatment, 1 hour sessions per week is because it fits with our calendars, but it's not what the body needs. The body needs shorter treatments at a closer interval. As a result, you're going to need to do more frequent half-hour sessions. So your first appointment, your first intake needs to be an hour. Okay, is it a newborn? Yes. Is it a cranial case? Okay, that needs to be an hour session. I have an online booking system where I can work independently without a secretary, and I'm able to set intake questions. So you might want to look at whether you can program that. The person has to answer, are you an existing patient or a new patient? Is this for a mother or a child? If it's for a child, is it a case of cranial molding? Is it a cranial condition, torticollis? If they answer yes, then they have to book an hour session, right? So you can break down the types of appointments. Once you're now a specialist, you might need to have a special fee schedule and a special appointment type and appointment duration that is going to reflect this. Remember, you're going to a higher level with your practice. You're presenting yourselves and positioning yourselves in order to be specialists. And that means making modifications to the way you manage your practice, even if it means that you're working within a clinic that is managed by someone else, where you have to go to them and say, okay, you know what, I need to make some changes. And it means making some changes at the front desk. It has to happen. Okay, so shorter sessions with a more frequent interval, and you need to be able to plan those out. That's the first thing. Second thing, and this is if you're talking to the mother, you need to say, there's going to be growth spurts, okay? So what we're gonna do is, what I'm gonna recommend that you do is a series of sessions, but know that it's not gonna be after each treatment that we're gonna see results. It's not like when you go to the gym after each workout, do I have bigger muscles today, right? It's over the long term. And remember, there is also growth spurts, Mother Nature, which we discussed earlier. And so therefore, there's going to be times where you're going to do a few treatments. You're not going to feel like you saw much results. And then all of a sudden, there's going to be like this huge growth spurt. Mother's going to come back the next week and say, look, he's so much better. It seems like that last treatment that you did achieved a lot. Well, it's not. It's cumulative. And it's also the growth spurts that also come in at very specific and peak times during a child's development. Also, even though you might say to the parent, you need to come in at this interval, you do need to be realistic about what the mother can achieve. And so if a mother can't come in at the frequency that you would recommend, you need to know that your results are going to reflect that. And that means that if you can only treat the child once a week, or if the mother has to miss some weeks because she books appointments and then has to cancel them, you cannot take on the same level of responsibility in terms of the results that you want to be able to give. That means that you have to explain this to the mother. This is going to be the protocol and the interval that I'm going to recommend. If you're not able to keep all of those sessions, know that we might not achieve the same degree of results. I can't guarantee the same degree of results, or it might take a little bit longer. So I always say, if I need 8 sessions, I would like to do 8 sessions within a 4-week period, twice a week, rather than 8 sessions that we drag out over 3 or 4 months because you can't make all the appointments. You're going to end up needing 10, 12 sessions. So if we can stick to a schedule and do it properly, we're going to have better results. It's like anything. You have to stick to a program when it comes to cases like this. And this is where you'll see whether or not you're working with a mother who is going to work with you or who's going to work against you. And when you're taking on a case of cranial molding, you're taking on a case where you're really working over the long term, right? So this is a long-term relationship. This is like you're taking on somebody to be their coach. You want to know that they're giving you a fighting chance. You want to feel good about that relationship with that mother. You don't want to be like, oh, how are you? Everything's wonderful. I'm doing the best I can, in the treatment room. But when you leave the treatment, you're like, this mother doesn't show up when she's supposed to. She originally had booked for 2 sessions a week, but she's only come in for 1 a week for the last 3 weeks. I don't know what to do. If you can't be under pressure to give results if you're not being given a chance to be able to achieve those results. So you need to be able to have an open and honest and transparent conversation with the mother about that. Say, this is the interval that I'm going to suggest. You'll achieve results if we can follow it. This is clinical. I'm recommending this to you, my students, based on my 17 years of experience of what works, right? So it is based on, empirical fact. I'm not just pulling this out of the top of my head. So what are we going to look at? We're going to look at whether or not the mother can commit to that. And generally speaking, if people have excuses, right? People have like daycare and this and that, but it's like anything in life. If a person is serious and they will commit. Parents care about their children. One of the things that I love in working in pediatrics is that, they're probably the appointments that people miss or cancel the least, because parents will do anything to make sure their children are healthy and safe. When they're doing treatments for themselves, they're more likely for them to be some attrition and for them to be some fall off in terms of showing up for appointments. So the good thing about it is that, you know, a normal mother is going to be very motivated to do whatever she can. If she is reluctant or unwilling to commit, then you're already up against factors that are out of your control. And so then you have to say, you know what, okay, well, I can only do what I can when you give me a chance to. If you can't commit and you can't show up, then just know that, you know, the results that I'm going to give are going to be partial as well. And I even go so far with patients who don't want to commit to what I know they need to do in order to achieve results. I say, you know, I'd rather not take you on as a patient. Or, you know, I might treat the child occasionally, but God forbid, don't tell anybody that I'm their osteopath, because I don't want my professional reputation to be associated with cases that I wasn't successful in. Because you're not going to tell your neighbor, you know, it was because I didn't show up. You're going to say, oh, I went to them like 4 times and look at, he's still the same. Yeah, 4 times over a year when it should have been 4 times over 2 weeks, right? So you need to be able to discuss these things openly and honestly and see how the mother feels. Maybe they want to go home and think about it. Most of the time with me anyway, mothers will say, okay, I'm ready. Let's go ahead and book. And so you can, you know, set that all up with them before they leave. The mother actually leaves feeling very good, feeling like, okay, I had a good consultation. I know where I'm going with this. I've got a plan of attack for my baby. The mother should go home feeling relieved. If they don't commit, it's either because they need to think about it, or, you know, they weren't really sure what they wanted to begin with. And even the best, you know, practitioner in the world is not going to be able to assure them, right? Sometimes some people have a lot of insecurities. They're just unable to commit overall. That's not about you. That's all about them. Those developmental growth spurts that I talked about earlier are also going to be a factor. So our treatment protocol interval is going to diminish and change a little bit as we go. Okay, so let's take a look at that. Scroll down on page 8 of your handouts, and let's look at the type of treatment protocol and interval that I recommend. So, as I said before, when we're working with newborns, I think that we can achieve a treatment, you know, that lasts about 20 minutes at the very most. If I can do a full 20-minute long treatment on a newborn or a child, like, I had a really great day. Because they'll fuss, they'll cry, and if you try to go on out longer than 20 minutes, sometimes the child will fuss so much that you just know you got to give it up for the day, right? So half-hour appointments with 20-minute treatments planned at the most is what your sessions should be. Now, that doesn't include the arrival time of the mother, the undressing, the getting them ready, the everything that surrounds a mother traveling with their baby. Mothers travel with a lot of stuff. They might come in with strollers, they might come in with a baby bag, they might need to change the diaper, they might need to undress the 5 layers that they're wearing because it's winter time. There's a lot of setup time that leads up to that 20-minute treatment. Factor that in. In some clinics where the practice is focused on family health, there is a waiting area or there's a setup somehow so that by the time the child comes into the treatment room, they're already all set up. Or there's assistants within the clinic, the receptionist who can bring them in. Or there's an area I used to have where, you know, coats and boots out there. You don't drag your coats and boots into the treatment room. It means that, you know, we have to wait another 15 minutes after the treatment's over for them to dress the child and then dress themselves. Your time in the treatment room is not all about them getting dressed and undressed. This is not massage therapy, where you leave the person, you know, 15, 20 minutes after their massage to come to consciousness and wipe themselves off and now get dressed, and you need to leave a half an hour in between your treatments in order to allow the person to settle in and to get off the table. This is not the case with a cranial treatment protocol. Half-hour appointments, 20-minute treatment during that half-hour appointment. That means that when you come in, the baby should be waiting for you. You do the treatment, we're done. You're coming back later this week and we're doing the same thing. So you don't want to get caught up in the rather energy draining scenario whereby the mother, each time they come in, she wants to give you an update. Oh, this is what's happening new and this is the latest and I'm home with my child and I'm just operating at a much slower, different speed than you guys are in the real world. So you can get some mothers that are just working at a much different speed, and so you need to manage that. You also don't want to get caught up in the situation where the mother is going to ask you at the end of each treatment, so how do you feel you did today? Did you get good results? What do you think is going to happen tomorrow, right? This is a mother that wants to do a full consultation with an intake at the beginning and a prognosis at the end. We're not doing this if we're doing cranial molding protocols because they're coming in for half-hour sessions twice a week. You're going to explain to the mother during your intake that we're going to set the appointments up in a certain frequency and interval. And after we've done a series of sessions, then we're going to have a meeting where we're going to discuss outcome, how much the child has progressed, what do I see as having improved in their cranium, what do I feel I still need to work on, and what is our plan of attack from here on? Are we going to go with more treatments, or are we done for now? So when the mother comes in, you're just doing a treatment. Okay, today is Monday. I'll see you Thursday. Mother comes in, you come in, you do the treatment. I'll see you next Monday, right? We're going to do maybe 4 in a row like that, for instance, or 8 in a row, whatever you decide. And if the mother starts wanting to ask for updates, say, okay, we had agreed that we were going to do a certain amount of treatments, and then we were going to sit down and have a consult. I've booked these as half-hour appointments. I'm charging you as half-hour appointments, and as a result, we don't have time to do a consult. Maybe the mother say, yeah, but there's something I need to discuss with you. Okay, so, then you look at your schedule and you take more time if you need. I don't recommend that you book 45-minute or hour-long sessions twice a week because it creates a dynamic where the mother feels that each time she comes in, it's a whole consultation, and it can be very draining for you, and it can start leading to expectations within the dynamic between you, the mother, and the child that you can avoid if you're doing sessions of treatment. Then you have planned a meeting later on where now we're going to sit and discuss. Believe me, I'm making this recommendation to you based on experience, right? When I had mothers who would come in from far and they would book a whole hour, and every single time they wanted to reassess and reassess. It's like you having to go through a performance review every appointment twice a week with this newborn. It puts you under a lot of pressure, right? Did you feel anything different? Did you notice an improvement from 2 days ago? Well, remember I had explained to you, this is what you need to tell the mother, that there's going to be growth spurts. We're going to do some treatments. Sometimes we'll do 2-3 treatments in a row. We might not see a lot of difference. Then all of a sudden there might be a growth spurt, and then the bones are really going to fall into place. So let's not fall into the habit of wanting to reassess after each treatment. That's not realistic. That's not the way the human body works. But more, we're going to do a series of treatments, and then we're going to assess what we've achieved and whether we're going to go on. Okay, can we agree that that's the approach that we're going to take? Yes, no, right? So if you say to the person, let's agree that this is the approach that we're going to take, when they come in for those appointments, they're on board. Okay, that being said, what kind of interval are we talking about? Well, I mentioned 20-minute sessions twice a week. I've already said that a few times. So that can be, let's say, for 4 weeks, maybe 8 sessions. Remember that when you're doing your initial assessment in that hour-long beginning, using the full assessment protocols that I've given you in previous classes, you should have a bit of an idea of, is this like just a few sessions? Do I think I can achieve everything depending on their age? Within 4 sessions, 6, 8, or maybe 4, and then afterwards, I don't know. I don't have a lot of experience in this. This is where you can make your decisions and say, okay, let's plan 4 consecutive sessions over the next 2 weeks, and then we'll reassess. This is something that we may have to work on over the long term. He's 2 months old now or 6 months old now. We're looking at working with him throughout his growth spurts over the next 6 months. So ideally, what I'd like to do is be able to do a few sessions until I've accomplished what I think I can, and then maybe spread out and do sessions with a more longer interval in between. So what does that mean? That might mean 4 sessions over 2 weeks, but that's only 2 weeks in the child's life. So you might be just starting. So you might say, okay, we're going to do 4 sessions, within 2 weeks, and then we're going to reassess. And then that also helps you to be able to say, you know what, now that I've seen what I actually am able to accomplish within 4 sessions in 2 weeks, now I know that I need like 10 sessions with this child. Okay, so now you need to explain this to the mother. Maybe you need to start working in shorter groups of sessions in order for you to gain your confidence. If that's what you feel that you need to do, that's okay. Myself, based on experience, can tell you that you can easily say, we need to start with 8 sessions over a 4-week period. Do you think that you can commit to that over the next 4 weeks to bring the child in for half-hour sessions twice a week for the next 4 weeks? If the mother says yes, you say, okay, so we're going to do this. And then after those 8 sessions, we're going to book a time where we're going to reassess. Maybe you're not going to charge her for that consultation where you're going to reassess. And then we're going to decide, do we need 8 more sessions? Do we need 4 more sessions? Maybe the mother has said, okay, or maybe you say to them, I'd like for you to give me a window of opportunity of 4 weeks where I can do 8 sessions and see what we've achieved in terms of results. If you're happy with the results and I'm happy as well, maybe we'll continue with a few more if needed. If not, maybe we'll talk again about the option of having them fitted for a cranial molding helmet as well. So maybe you're willing to concede the fact that maybe you'll be doing your treatments in conjunction with a cranial molding helmet. That's fine. If you feel that you want to do that, not every therapist wants to take on long-term cases whereby, you're doing like 10, 20 sessions. That's fine. It's your choice. You might say, you know what? I am comfortable working with mothers who want to have their child fitted for a cranial helmet. I like to try to do a few sessions, 4 sessions before they're fitted for the helmet. Then if you want to get him fitted for the helmet, then maybe have him come in once a month, once every 2 weeks during that helmet wearing time, so that I can work on ensuring the cranial bones and the sutures are moving, like we talked about earlier, and also work on some of those other bodily things, right? So you're free to choose to do that as well. You don't have to be the only solution. If you feel that being the only solution to a really complex cranial molding case is putting a lot of pressure on you, and the mother's saying, the doctor's office called and that appointment for him to be fitted for that helmet is coming up in 2 weeks, and you're feeling more pressure than you're comfortable with, you don't have to be brave. You don't have to say, don't worry, I can handle this. And meanwhile, you're going like, I don't know if I can handle this, right? You can say, okay, you know what? So let's talk about it. Do you want to go ahead with the helmet and I continue with treatments, right? You don't have to be the only solution. So know that. You can be if you choose to be, and you make that collaborative decision with the mother, but you can also work in conjunction. So here's where setting up your treatment protocol, you're going to need time to be able to sit down with the mother and discuss this. If she says, okay, well, I've got this appointment in 3 months' time with this cranial molding orthopedic department, what do you think you can do in the next 3 months before then? Or you can ask the mother, do you have other follow-up appointments planned? Like, what's my window of opportunity to be able to help your child? Okay, so then let's come up with a plan. We're going to do that like this, and then we're going to reassess, and then we're going to see, do we want to go on with a helmet? Do you want to continue working exclusively with me? Either way, I'm comfortable. What's most important to me is that your child be the best care. I don't have to be the only solution. So for some practitioners, that takes a little bit of the weight and the pressure off them when I tell them that, and they're actually surprised. So I say you don't have to be the only solution. You can be the adjunct therapy as well. Nevertheless, I recommend, if it's a case of cranial molding, plan the 8 sessions and then plan on week 5, because you're going to do 2 sessions week 1, 2 sessions week 2, 2 sessions week 3, 2 sessions week 4, follow up, maybe no charge, however you want to do it. Charge them, don't charge them for your consultation with the mother, where you're going to say, okay, now I have time to sit and just talk with you. This is what I found. This is how far I feel I've progressed. I feel like this is not going as quickly as I'd like it to. Therefore, let's talk about some of those other options that you had in mind. Or I feel it's going really well, but I need a few more sessions. Do you agree? Can we go ahead, right? And so you're setting yourself up for success. You're working in collaboration with the mother, and believe me, mothers really, really appreciate this type of approach. So on your 9th appointment, which is your reassessment, you're going to determine whether or not more treatments are needed, You're going to determine what the interval is going to be, and then you're going to go ahead and book them. So maybe after 8 sessions in a period of a month, the mother says, you know what, like I made these appointments, but it's too much. I've got other children, I've got work. And so you're going to have to find a middle ground. So you might say, you know what, I achieved a lot in these 8 sessions. Okay, let's agree to once a week. Can you do once a week? Okay, once a week for the next 4 weeks, and then we'll reassess again. Now he's 6 months old. Now he went through that huge growth spurt, right? Depending on the age of the child and the different growth spurts in those key developmental stages, you might find that, you know, some children recover quickly when they're a little bit older, when they've had a chance to go through those growth spurts, than when you're working on a child that's, let's say, 2 months old. Right? If you're working on a child that's 6 months to a year old, there's going to be times where they're going to go through growth spurts. And so Mother Nature is going to come in and help you. And you're going to find that in the same amount of treatments as if you had worked on a 2-month-old, you're going to achieve better results because they're going through those growth spurts. So the growth spurts are actually helping the work that you're doing. I always explain to mothers that I give Mother Nature a helping hand, right? And then Mother Nature comes in and allows the child to bloom. I'm working in conjunction with what the body would do anyway. So whether or not you're going to set a particular protocol, whether you're only going to have a chance to do a few sessions, there's always going to be some key points that you need to remember when you're doing cranial molding treatments, okay? And so you might say to yourself, okay, but you know, last time I had a case of severe shunting and the child being stuck in extension. This time I have a case of, you know, severe torticollis and I've got a torsion. The needs of the cranium are completely different. Nevertheless, your goals are always going to be what? To ensure that the sutures are properly decompacted, whether the infant is wearing a helmet or not, right? So if they're going to go ahead and have the helmet, you still need to see them to ensure that the sutures are all properly decompacted, that they're properly level and beveled, that they're not overlapping, and that the cranial bones are not overlapping. You need to do that regardless of whether they're signing on for a protocol or not. You need to make sure that the sphenobasilar symphysis is able to have full amplitude, where the occiput and the sphenoid are able to move fully into extension, fully into flexion. Remember, a young child, it's very hard to be able to feel the movement of the sphenoid, and so very often you're going based on the movement of the occiput. So if a child comes in, you've done only 1 session and you just barely got that stuck occiput starting to move, but you still haven't got it into full flexion and full extension, child's not finished. Even if I have a young child that's 5, 10 years old, if they've come in for a couple of sessions and somewhere along the way I lost track of them, and I know that the sphenobasilar symphysis of that child, I haven't been able to do enough treatments to fully bring it into full amplitude of flexion and extension, I'll call the mother back and say, this is crucial and I haven't finished. You need to bring the child in for 1 or 2 more treatments. Very important that I get the sutures decompacted, leveled, and beveled, that I make sure that the sphenobasilar symphysis has full amplitude. And also, then your next priority is going to be to make sure that each cranial bone is also able to move fully in flexion and extension. For example, the frontal bone, right? So our frontal bone, as we know, overlaps the parietals at a certain period when it comes through the birth canal, right? And can get stuck. We can have, you know, a very cone-shaped, high elevated vault, whereby the frontal bone can be shunted in the same way that the occiput can. So you want to make sure that you have time to be able to work on increasing mobility of the frontal bone. If you have a torsion, you know that very often in a torsion, what happens is one side of the occiput is going to be pushed in and one side of the frontal might be out. So you might have a bit of a parallelogram shaped head. And so you need to do cranial molding to ensure that the cranial base is even, level, that both sides of the occiput are able to come out and move fully into flexion and extension. And whether or not one side of the occiput is compressed and pushed in or the other or not, same with the frontal. We want to ensure that the frontal bone is not sitting, you know, in a kind of a strained position like this or like this, or like that or like that. So we want to ensure that it's able on both sides, occiput, frontal, sphenoid, both sides, able to move fully in flexion and extension. And we also want to make sure, depending on the age of the child, with regards to the temporal bones, remember that if a child is under 6 months of age, we cannot yet really distinguish the mastoid bone. The mastoid bone only grows later, but we still want to make sure that the temporal bones are able to rotate fully in flexion and extension, that the occipitotemporal suture, where the occiput meets the temporal, is even and beveled and is closed properly. I've seen cases of autism that where children were brought to me older, later in life, whereby the occipitotemporal suture on one side was extremely open, like almost like a fontanelle that didn't close, and on the other side is very extremely compacted. Okay, remember I said making sure that the sutures are open and able to open and close, leveled and beveled is very important. So if you have one side that is highly compacted and the other side which is highly open, you have a huge cranial torsion there. Cranial molding is needed. Also, our parietal bones, right? Our parietal bones, what do? They overlap everything. And very often, they are the last point of compensation of any kind of abnormality that might have taken place within the sphasino-basilarys symphysis, within the temporals, and within the frontal, right? So the domino effect is often upward to the parietals. Remember also, if the baby, for whatever reason, has been subject to any type of a vertical strain with, like, using vacuum or forceps, you might have a cone-shaped head, and you will have strain on the membranes, whereby it's going to be very important for you to take some time to work on that vault to be able to normalize the meninges and get the meninges moving there as well. So those are going to be some of the priorities that you need to take into consideration when you're saying to yourself, have I achieved what I need to achieve? How many more treatments do I need to work on? Well, I did this, I got that, but I still need more of this, but I still need to do more of that. So yeah, I've got like 3 to 5 more sessions that I need to do. And then I'll reassess. I need this much as a fighting chance. This is what I tell patients. Remember that a little bit like an auto mechanic. When you bring your car into the auto mechanic, they will say, this is a job that has 3 hours of work. This is a 1 hour job. This is a 1.5 hour job, right? So the same way, you need to be able to assess and then say, you know what, I need at least this much time, and then I'll reassess, and then we'll see if we need more time. Can you tell me how many treatments in total now? No. I recommend that we start with a series of sessions, we reassess, and then we see if we need more. This is the realistic way of going about it. Okay, now let me just see if there's any other questions that we need to address. Okay, techniques. So someone wants me to talk a little bit more about some of the techniques, and I'm talking a little bit about that right now anyway, some of what your priorities are going to be. And of course, we're going on the assumption that you're already very well versed in cranial osteopathy. If you're not, and you're interested in training in pediatric osteopathy, you might want to look at going back and taking our intro course. Nevertheless, as I mentioned, some of the most important areas that you're going to want to look at and some of the most important techniques that you're going to want to incorporate are things like your occipital correction technique that we talked about. Right? So you want to ensure that the occiput is able to come fully into extension, also able to go fully into flexion, and that the occipital base is level. Ensuring that the occipital base is level and ensuring that there isn't compaction and compression of the cranial nerves might mean that you might need to do an occipital base expansion technique. And in that case, what we're doing is we're working to be able to open the foramen magnum, and we're working a little bit more on an oblique angle. So when we're working on bringing our occiput into flexion and extension, if the child is in front of us, we're working on this angle. But when we're doing an occipital base expansion technique, we're trying to open up a little bit more on an oblique angle. And this is going to help to relieve compression of the suboccipital condyles, where the occipital base is sitting on the first cervical vertebrae. So these are always very, very gentle techniques, but we're working to open more in an oblique fashion. Also, a way to be able to have a more direct effect of decompacting the occipital condyles is going to be to work with the child a little bit similar to a V-spread technique, in the sense that the occiput is going to be resting on your thenar eminence. So if we look at our image in our handout on page 10, you'll see that we're also working in a way where we're inducing a certain amount of compression in order to be able to release. Now remember, we're not inducing the same amount of force as we would if we were working on an adult. We're working on a newborn, so we're working very much in a fluidic fashion, very much within the movement of the membranes. But our goal, nevertheless, is to be able to try to get fluid movement and decompact, right? When do we have decompaction? We have decompaction when we feel that the tissues of a newborn are going to start to swell and inflate a little bit. Why? Because that means that the area that was compacted, there was a decrease in blood flow, there was a decrease in drainage of the blood system as well as cerebrospinal fluid. And with newborns, because the bones are still so cartilaginous, and we can see the veins and arteries pulsing, very often when you decompact an area, you're going to feel it kind of fill up under your hands in a fluidic fashion and also in an energetic fashion. That's a good sign that we've managed to decompact that area. Remember that an occiput that's been pushed in and flattened, which is often the case in a lot of forms of plagiocephaly, is going to mean that there is going to be adhesions, especially if we're working on a child that's a little bit older, right? The longer they've been left in that position, the longer that all of the tissues underneath are going to be a little bit stuck together. And I use the analogy with membranes, a little bit like pages of a book that have gotten wet. Oftentimes, you need to kind of take those pages and peel them apart. They don't tear, they're just kind of stuck together. And once you peel them apart, then they're able to move properly. So the membranes of the skull in a newborn or even an adult are a little bit of the same way. We need to be able to induce just enough force in order to be able to get them to start moving. Now, the frontal correction technique, as I mentioned also, the importance of being able to decompact the frontal is going to be very important. So very often we're going to work frontal in relation to occiput, or frontal sometimes even in relation to the sphenoid, and sometimes your hands are really one on top of the other. But also to make sure that that frontal bone is able to move fully in flexion and extension. As I mentioned earlier, because of the way the frontal bone and the parietals overlap when the baby comes through the birth canal, we want to ensure that that's disengaged and that's moving properly. Getting the occiput moving and getting the temporal moving in relation to the occiput is also going to be very important. Why? Because we've got the jugular vein, we've got the vagus nerve, so we've got a lot of important drainage areas that are taking place just underneath and behind the ear. And so if you have a child that needs cranial molding, that's displaying any type of plagiocephaly, but that's also showing any other signs of colic, digestive problems, behavioral problems, know that the pathway of the vagus nerve and releasing that might also be a treatment priority for you. And so ensuring that the area surrounding the temporal is released and moving properly is also going to be a priority for you. As I mentioned earlier, the vault molding procedure is often a way that a lot of pediatric osteopaths start, because they understand the importance of the baby coming through the birth canal and how all of the bones are contracted and compressed together. And so we can end up with that cone-shaped head, or that baby's head where the vault is elevated. The membranes have been pulled up, the baby's kind of like in a strain fashion. So what you want to do is you want to start releasing that and normalizing that. You can get a good idea of whether or not that is needed by looking at the shape of the cranium, but also looking at the fontanelles, the anterior and posterior fontanelle, and whether or not they're closing and beveling properly. So doing a vault molding technique in that area is also going to be very important for you, and ensuring that the sutures are going to be able to close, right? Our sagittal suture, but also our coronal suture. Sometimes we're not necessarily working on trying to decompact sutures directly and locally, but sometimes we're going to work on strains like a vault molding technique in order to ensure that these sutures are later going to be able to fall into place properly. So your strategy can vary depending on whether you like to work directly or indirectly. In our intro course, our online course, in the fundamentals of cranial osteopathy, I teach you how to disengage sutures that are compacted on an adult. but there's also more indirect ways that you can go about doing that when you're working on a newborn, and that might mean working on the adjacent areas that are contributing to the sutures being compacted. So know that the beautiful thing about osteopathy is that if it's maybe contraindicated to work directly on an area, you can work indirectly on another adjacent area that's affecting it. Putting together your cranial molding plan, I've included in the handouts on page 12 a cheat sheet that you can use in your clinic. And if you take a look at that, this is a sheet that I recommend that you use when you say, God, she covered so much material in this class, but where do I start? I don't remember everything she told me to review and discuss. Make a copy of this sheet, keep it in your clinic handy so that when a case like this comes up, you can just reach into your desk drawer and pull it out and say, okay, as I'm doing my intake with you, I'm going to, fill this out. And sometimes I even make a copy of it and I give it to the mother so that she can take it home, discuss it with her husband, review it, and then, make a decision. They like when you give them a summary of your findings, especially if you're charging a lot for an hour-long intake, to be able to take home something and review it themselves. So what are we doing? First, we're talking with the mother. What is the mother's primary complaint? What did she come to see you about? She might have come to see you because the child is, suffering from colic, but in fact, it's a cranial molding case. So you want to be able to write out, what was the mother's motivation for bringing you in? Maybe she wanted a second opinion because she had been recommended a cranial molding, right? So you want to write, what is the mother's primary complaint? What you think is the priority might not be what the mother's priority was. So it's important that you identify that so that you're on the same page. You want to go through all of the developmental milestones and make sure, did the child achieve all of the developmental milestones for their age? And if you don't know them by heart, and I don't expect you to, in our previous class where we reviewed that, you've got forms that you can use. So you might pull out that form as well, go through it very quickly. Is the child sitting up? Are they doing this? Are they turning their head? Da, 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 da. Yes, they've achieved all of the developmental milestones, so that's not a concern, right? You can check that off. If not, what are your findings? What did you find is suboptimal? What are you concerned about? Then, based on all of this, what would be your steps to a cranial molding protocol? As I mentioned earlier, there are certain priorities that you want to take into consideration, but with this child, once you've assessed them, and assuming that you just did, you might say, okay, you know what? Repositioning the occiput, because the occipital base is really stuck in torsion, and getting that released and getting it aligned is my big priority, because the child is also suffering from torticollis. That might be your first step in your cranial molding protocol and your big priority. Then your second priority might be, the frontal, because it's actually, a torsion or some type of a lateral strain. Releasing the frontal, because the orbit of the eye, of one eye of the child, is actually maybe a little bit smaller, and I need to normalize and correct that, right? So you write down what all of your priorities are going to be in your cranial molding protocol. So that, as you've gone through that exercise, that gives you a way to say, okay, give me just a second if I need to go through this and that, and I need like 6 sessions to have a fighting chance with this child, right? Realistically, so I need to schedule you for 6 sessions, over the next 3 weeks, 2 sessions a week, in order for me to be able to try to achieve this. These are the things I need to try to achieve. I've written them down for you here in number 3. And then we're going to reassess, and we're going to see how far did we get in terms of my priorities, and whether we're going to go ahead with more treatments and at what interval those are going to be. So what do I recommend for my duration and interval? This is when you're going to write down for the mother, half-hour sessions twice a week. Maybe it's just not realistic. 45-minute sessions once a week for X number of weeks, total number of sessions. And then the mother has a bit of an idea of what you're proposing, what the game plan is going to be. Now, before I finish, I want to talk to you about one other thing that I've done in my practice that actually was recommended to me by a patient, and that has actually been very successful in terms of helping mothers be on board with cranial molding protocols. So it involves creating a package. Now, in some regulated fields, you're not allowed to create a package. In some you are. It's very common. Chiropractors do it. Other health therapists where you need a series of sessions do it. It's not at all uncommon. I found that when I started implementing it, and as I mentioned, it was I started it at the recommendation of a patient. I probably would have never thought to do it myself because where I was afraid of coming across a little bit salesy. But when I did it, I found that mothers or patients said, you know what? If this is a package, let's say you know that you're going to recommend 8 treatments, okay? 8 treatments, half hour, twice a week. What are you going to charge? Let's say if it were to come up to $650. Maybe you're going to offer that package at $500. I came up with a package that was $495. And my patients in Ontario loved it because a lot of people have extended health insurance that covers them for $500. So this came in just under what their annual insurance coverage permitted. This is something that you might consider doing. Now, depending on where you're located, depending the type of coverage that people have, nevertheless, creating a package where the person pays for 4 treatments, 8 treatments, prepays, would then allow them to be able to go in and pre-book their appointments. They get priority in booking their appointments over everybody else. My patients like that also because then I would sit with them and I'd say, okay, when are we going to book your appointment? You're going to be able to have it, you know, every Monday and Thursday at 1 o'clock for the next 4 weeks. That's your set time. We're going to pre-book them now so that you don't have to come in and book an appointment every single time. It also saves in a lot of, okay, when's my next appointment going to be? And when's the next appointment going to be? If you have to go through that with a patient who's coming in twice a week for 30 minutes, you're spending more time rebooking the next appointment than you are actually treating. So spending that time at the beginning to be able to explain to them what you recommend in terms of a protocol, and then saying, I put together packages to make it accessible for mothers who need to do this. This is how many sessions you would have. You have to do them in a certain time period. I recommend that we do it over the next 4 weeks, 8 weeks, whatever you've recommended. And you can pre-book your appointments. That time is set for you. I put a deadline in the duration during which they're able to use this package because the package is intended to make a protocol, which might otherwise be a bit expensive, accessible. It's not a membership. It's not, oh, I'm buying in advance a bunch of sessions that I can use and redeem whenever I want. No. When I have patients who buy the package and who don't follow through with their appointments, and it has happened, they disappear, not so much with newborns, but I did do it with adults. If they were to disappear, call me up a year later and say, you know, I want to redeem my sessions for my package. And I say, well, yes, but the package was intended as part of your treatment protocol. And you only did the first 2 sessions of your treatment protocol, and then I never heard back from you. You canceled your 3rd appointment, right? So you have a right to decide whether or not you're going to honor or not a package that somebody might have purchased from you a year ago. The purpose of the package is to allow the treatment protocol to be accessible. If the patient falls off, like they say, and doesn't follow through on the protocol, you know, they might come back to you with questions like, you know, I paid this much, can I use it for myself? Or can I use it for my husband? Or can I use it for other sessions because I didn't finish, you know, the protocol with my newborn? Well, then that'll be for you to discuss how you want, right? You're not under any obligation to offer 4 more treatments at 30 minutes at half price for someone else when they purchased it for their newborn. So explain to them that the package is intended to make the protocol accessible. It's with the intention that they're going to follow through with the protocol at the interval that you suggest. So what I do in a case like this is, as a result, the protocol is good for a 3-month period, 12-week period. It means that if you're going to come in for 10 sessions, they have to come in for those 10 sessions over that 12-week period. It forces them to stick to the protocol, which was the reason why you were giving them, you know, such a good price anyway. So this is something that you can implement or not. I'm just telling you what I did as a result of a suggestion from a patient, and it actually worked very well. I used to include it on my website with a link in the confirmation email to that page, so that when a patient would book an appointment, they would have a chance to look and say, look at some of our package options. And oftentimes I was quite surprised that people would come in and say, I saw on your website that you have a package. I want to buy that package because you told me that I need a series of treatments anyway. And you have a pediatric osteopathy protocol package. So can I purchase that for my child? You said she needs, 10 sessions, and you have a package for 10 sessions. Yes. So, you're not selling it. They bring it up because their goal is to save money. And that's the whole purpose behind a protocol, to help make it financially accessible for them, but also for you to be able to keep the patient on track. Because if you're going to take on a case of cranial molding and plagiocephaly, the last thing that you want is to be in a situation whereby the mother is expecting incredible results, but she's not giving you an opportunity to do the treatments or enough treatments to be able to achieve those results. Also, giving the mother the option to be able to pre-book causes her to commit to a certain time. And as a result, you can say, okay, well, I know where I'm going now. I know what my plan of attack is going to be for my next few sessions with this child. I know that she's not going to ask me to reassess each time. We're going to reassess after we do our 8 treatments. We've agreed on that. And so I've been given a fighting chance to see what I can accomplish. And then afterwards, this will also give you some confidence to say, in the past, when I worked on cases like this, when I did 8 sessions over a 4-week period, for example, generally these are the kind of results that I got. But I worked on a child that was older. I worked on a child that was younger. Your child is at this developmental age, so it might take more, it might take less. But based on, what I've been taught works well and what I've seen works well, this is what I recommend that you do. From there, the mother can then decide what does she want to do with you. So when you go into doing your treatments, you've had the opportunity to plan, and getting up and knowing who your patients are going to be that day. Already you're thinking, I'm going to do this with that one, that, and that, right? Your stress levels go way down, as opposed to being the type of practitioner where people call at 5 to 6, and you usually finish at 6 and say, have you got any room for a last session today? I don't know if I'm getting old, but I'm tired of the last minute appointments. And when you know where you're going, especially with a case of cranial molding, your stress levels go down, your performance anxiety goes down, and you're able to just focus when you're in the session with the newborn of giving results and just focusing on being able to do that treatment and be able to release and bring health and vitality and growth to the newborn, so that you can give them a fighting chance to grow up healthy and happy and strong. And in the end, that's all you can hope to achieve as a pediatric osteopath. When I've traveled to locations, remote areas, sometimes I've had members of the community say, can I get a treatment with you? I say to them, I'm just here for the babies. I'm here for the newborns, to help them have a fighting chance to grow up healthy and happy and strong. If you make that your mantra, and if you project that and talk about that to the baby's mother, she's going to see that you're committed and that there's a belief behind what you're doing, and that you truly are a pediatric osteopath who cares about the child and who wants to help them be able to grow up healthy and happy and strong. And hopefully, if you're practicing pediatric osteopathy, it's because you feel a calling. It's because you want to be able to do that. I myself never had any children, but I love working in pediatrics and I love working in obstetrics, because maybe part of me feels like every little child that I treat, is my own, vicariously, my own spiritual child that I'm helping, everywhere throughout the world, through you as students and through the babies that I've treated in different communities, to grow up healthy and happy and strong. So if you want to make that your mantra, go right ahead. You're welcome to steal it from me. When you're doing cranial molding, that is what your goal is. Long-term, setting up a protocol, knowing where you fit within the medical community, knowing what you as an allopathic practitioner can offer as an alternative or in conjunction with the medical community, what the mothers are going to expect, the kind of questions that they're going to ask, what you realistically think that you can offer. And if you don't know, you don't know. I said, I don't know, I've never worked on a case like this. There's no problem with being able to say, I don't have a lot of experience in this, but this is the way I've been taught to do it, and this is the way I would like to go about it with you. I find honesty and transparency and sincerity really goes a long way towards establishing a good rapport with the mother, which is extremely important in terms of building your reputation and building your credibility. And that's what's going to go about helping you in order to build your practice. So we're going to wrap up for today. I think we've covered just about all of the questions that we had. But like I said before, if you have any additional questions, you're welcome to write to me. If you want to look at some of the classes that we got going on, take a look on our website, ceosteopathy.webs.com, and our online platform, which is ceosteopathy.thinkific.com, or just send me an email directly at ceosteopathy@gmail.com. Have yourselves a great day and get out there and heal those babies.